My name is Brooke Phillips. I'm the Marketing Manager with Shield Healthcare, and I'd like to welcome you to today's webinar on managing incontinence in Alzheimer's disease and dementia. Before we begin, just a few housekeeping items. Attendees will be in listen-only mode. If you have a question, please type it in the question box on the right-hand side of your screen. A PDF of the presentation slides is also available as a handout that you can download directly from the webinar. If you registered as a healthcare professional and would like to receive CE credit, look for an email from Capital Nursing Education containing your CE certificate within 10 to 14 business days. If you miss any portion of this presentation or would like to share it with a colleague, the webinar is being recorded and will be available on shieldhealthcare.com/community by the end of the week. Now I'm delighted to introduce our presenter today, Kelly Sparks, RN, BSN, CWOCN, CFCN with Capital Nursing Education. Kelly Sparks has been a CWOCN for over 25 years and a nurse for more than 30. She's worked in wound, ostomy, and continence care for most of her career. Kelly has been on the board of the Directors of Pacific Coast Region several times in the past, as well as being on multiple projects for the WOCN Certification Board. She's active with the local Sacramento WOC Nurse Group, where she serves as secretary. Kelly is recently retired from Dignity Health, but continues with her private practice. She's been a speaker for many different conferences and classes. Kelly enjoys speaking for Shield webinars and working with Capital Nursing Education to help promote education necessary for the care of patients. At this time, I'd like to pass the presentation over to Kelly. Kelly, it's all yours.
Thank you, Brooke. Good morning, everybody. It's a beautiful rainy day in good old Sacramento. I hope you guys are all doing well. We are going to talk about Alzheimer's patients and other types of dementia in regards to incontinence. So we will just carry on here. The screen isn't moving, but I'll move it anyway. Okay, so many people with Alzheimer's and other types of dementia experience a loss of bladder and bowel control, especially in the later stages. So in this session, we're going to explore the different types of dementia, the factors and the medical conditions that may cause or contribute to their incontinence, as well as the methods for incontinence management with somebody who does have dementia. It's a little different for those people. So the types of dementia, we're just going to touch on those real quick so that we have an idea of a few of the different types. Alzheimer's disease, it's the most common form of dementia. It's caused by, of course, the physical disease in the brain. So the death of the blood or of the brain cells occurs when there are these plaques and these little tangles that of protein that develop in the brain tissue, in the structure of the brain. So it's combined with a shortage of chemicals involved in transmitting the messages within the brain, and that leads to a very progressive deterioration in function. So as parts of the brain are being damaged. It definitely has a component of loss of memory, of judgment, of language. It can go that far to where they just can't even talk. And usually between 60 to 70% will be incontinent. So some type of incontinence. And incontinence should not be considered an inevitable part of their illness, though, because there are other types of incontinence that they could have that has nothing to do with Alzheimer's. Treatments are available to help with incontinence, and so Alzheimer's patients don't always have to be incontinent. It is treatable in a lot of cases. The second most common form of dementia, that is caused by problems of the brain's blood supply. So, for example, a stroke. Vascular dementia it can affect people in many different ways. And as the disease progresses, it varies from person to person as well. So there's some problems there you can see that can happen with vascular dementia. That would be communication and concentration. They can get really anxious. They can have depression and memory problems and behavioral changes. Their mobility can be affected, continence problems, and just overall weakness can happen with these people as well. So frontal temporal dementia, it's a little different. It's one of the less common forms, and it covers a range of specific conditions, which sometimes can be called Pick's disease. And that's in the frontal lobe that's right here behind the forehead. Damage to these areas or buildup of the proteins can lead to difficulty in controlling behavior and emotions and language. People with this condition have what's called abulia, which is the failure to initiate. And these people, they may not recognize that they need to find a toilet when the urge presents. So that abulia is very, very difficult. Pick's disease is known especially for its aphasia that it does cause as well. And the other thing is you cannot tell, it's very difficult to tell the difference between Alzheimer's and Pick's disease, because they both have these proteins that build up. The only time they can really differentiate is post-mortem by pathologists. So it's not as common as the other kinds. Now, Lewy body dementia, this is one I find extremely interesting. I was madly in love with Robin Williams, and he did have this kind, and that's one of the reasons he took his own life, according to what they say. But these are tiny little spherical proteins, and they're found in the nerve cells. So the presence of these Lewy body, it disrupts the brain's function, interpreting. It just totally interrupts everything. The actions of important messengers that they're found in the brains of people with Parkinson's sometimes. And it is progressive, and it can lead to problems with the spatial disorientation or coordinating mental activities. People with Lewy body dementia, they may also present with some Parkinson's type symptoms, such as the slowness and the muscle weakness and trembling limbs and stuff like that. So let's do some kind of interesting review of the nervous system regarding how bowel and bladder are innervated. We're going to look at neurons first, and the nervous system, it takes information through our senses, and it processes the information and triggers reactions in our body, such as making your muscles move. You all know that. There are billions of nerve cells, also called neurons, and the brain alone has about 100 billion neurons in it. Each neuron has a cell body with various extensions called dendrites and the axons. The axons can be up to 1 meter long. Dendrites are like the antenna, and these messages all go through these extensions in the on the cell. So we have central and peripheral nervous system. The central nervous system is protected safely in our skull and the vertebral canal of the spine. Peripheral nervous system is related to all the other nerves in the body. So the voluntary, we have voluntary and involuntary. Voluntary system, nervous system is the somatic nervous system that we're all familiar with, and it controls things that we're aware of and that we're consciously influenced, like moving arms and legs and other parts of the body. The involuntary, or the vegetative or autonomic nervous system, that regulates the processes that we cannot consciously influence, such as your breathing, your heartbeat, metabolic processes, things like that. It can also send signals the other direction from the body to the brain, providing the brain with the information about, for instance, how full your bladder is or how quickly your heart is beating and things like that. So Alzheimer's patients may feel the feeling but not be able to recognize what that feeling is about when their bladder is getting full. They may not realize that they're hot or cold even, and they just are uncomfortable. So you have to kind of read what is going on with Alzheimer's patients. The involuntary nervous system is made up of 3 parts. We're looking at the the sympathetic, the parasympathetic, and we're going to look at the enteric, or the gastrointestinal nervous system as well. Now, the physiological function of the bladder and the bowel is reliant on several areas of the brain, including the cortex, the pons, the basal ganglia. All of these parts of the brain are very, very important in terms of bowel and bladder. Between them, they're responsible for the conscious control of the bladder, the social voiding, the cerebral micturition center, the interpretation of sensory information, the detrusor muscle itself, the control and coordination of the bladder and the sphincter. Also, by the way, the cortical atrophy that happens in dementia, that's degeneration of the brain's cortex. That's common in many forms of dementia, and it can have an effect that way as well. So the sympathetic, we know, prepares your body. It makes your heart beat faster and stronger. It opens the airways. It works the same for Alzheimer's patients. It's not affected by that. But the parasympathetic, that is responsible for bodily functions when we're at rest, it stimulates digestion, activates various metabolic processes, and helps us to relax. So the enteric, this is the one that is just so interesting to me, because this is its own separate little nervous system for the bowel. And to me, yeah, bladder and bowel are my thing, right? So to me, this is the most important one. The enteric system, or the intrinsic nervous system, is one of the main divisions of the autonomic nervous system. It consists of this mesh-like system of neurons that governs and functions the whole GI tract. So it's composed of thousands of small little ganglia that lie within the walls of the esophagus, all the way down the stomach, the small and large intestines, the pancreas, the gallbladder, biliary tree, nerve fibers that connect these ganglia, and the nerve fibers that supply the muscles of the gut wall, the mucosal epithelium, all of these things, arterioles, and any other tissue in there. The large numbers of neurons are contained in the enteric system. There's about 200 to 600 million neurons. Now that's far more neurons than are in the peripheral organ, any other peripheral organ. And it's similar to the number of neurons in the spinal cord. So that's how important this is. As long as there's no spinal cord injury, the Alzheimer's patient still has all these nerves working to make sure that their GI tract is functional. So enteric, I don't know why, but this just thrills me to pieces. So functions of the enteric system: the peristaltic activity of the esophagus. That takes the food, of course, from the mouth down to the stomach in about 10 seconds, where the food is mixed with digestive juices. And then the gastric emptying proceeds over probably about 1 to 2 hours after eating, after a meal. In the Alzheimer's patient, however, when they're more advanced, the peristaltic time may be different depending on how well they can still remember how to chew and swallow, because sometimes they lose those abilities. The fluid from the stomach, is then mixed and makes the chyme, and the chyme moves slowly through the intestines. And then this is all under the control of the propulsive movements orchestrated by the ENS, or the enteric nervous system. And that's happening while digestion and absorption of nutrients is going on. So everything is orchestrated to work together. The average transit time through the human small intestine is 3 to 4 hours, and the colonic transit in healthy people is 1 to 2 days. So with Alzheimer patients, that might be a little different depending on where they are in their disease process. The enteric nervous system is programmed to produce different outcomes too. The major muscle movements in the small intestine are the mixing activity. One is propulsion and one is retropulsion, which would be in vomiting. The intensity of this gastric contraction and relaxation, that takes place, and this says valgus, I'm sorry, it's not valgus, it's the vagus nerves. And the primary center for control of gastric motility is in the brainstem, whereas the control of the small intestine and the large intestine is in the enteric nervous system. So very, very important part of the body, this enteric nervous system. There's even more functions. It regulates even the movement of water. We're looking at the fluid exchange and the local blood flow. It's of prime importance for maintenance of the whole body fluid. So for instance, these neurons, they act again in concert with the autonomic nervous system, which controls other vascular beds to distribute the cardiac output to where it needs to go. So in times of need, even during digestion, the sympathetic can still divert that blood if they need it to flow away from the gastrointestinal tract. The cardiac can still get what it needs. It's so interesting how the ENS works. Enteric neurons also are involved in a number of defenses, and these defenses would be, for instance, diarrhea, which is to dilute and eliminate toxins in your body, and then exaggerated colonic propulsive activity, which occurs when there are pathogens in the gut. It wants to get that out of there. And then, of course, vomiting is also one of the defense reactions that the enteric nervous system takes care of. So the enteric reflexes, signals between the gut regions are both by hormones and by nerves. So a lot of it is hormonal and a lot of it is nerve. Enteric reflexes regulates one region in relation to others. For example, when nutrients enter the small intestine, secretion of enzymes go from the pancreas. It's a series of nerve circuits that carries signals from one region to the other and back to the gut wall. So that's how that works. These signals are, it never ceases to amaze me. So the GI tract is a two-way communication with the CNS. Okay, so afferent neurons convey information about the state of the GI tract. Some of this reaches consciousness and others don't. So consciousness would be including pain and discomfort from the gut, the conscious feeling of hunger or satiety, either one. Those are integrated perceptions derived from the GI tract and other signals such as blood sugar, etc. So this may not be recognized by the person with dementia. They may not know that feeling. What is that feeling? They have no clue. Other afferent signals concerning, for example, the nutrient load in the small intestine or the acidity in the stomach, okay, that normally, it doesn't reach consciousness. So therefore, it's not affected in the person with dementia. In turn, the CNS provides signals to control the intestines, which are, in most cases, relayed through the ENS. For example, the sight or smell of food may make you, the preparatory. You're gonna have some salivation going on, like if you see a lemon, or my son one time painted his room this bright yellow, and when you walked in there, your jaws hurt. It was amazing. And that's the cephalic phase of digestion. Swallowed food stimulates the pharynx and the upper esophagus, eliciting efferent signals that are integrated in the brainstem and subsequently provide efferent signals to the enteric neurons in the stomach that causes the acid secretion. So we are very well orchestrated in our bodies. So we're going to look at the effects of the of Alzheimer's disease and dementia on the urinary and the GI tracts in just a few minutes. On the other end of the gut, signals from the colon and rectum are relayed in the centers in the spinal cord, and from which is programmed the signals, a set of signals that's conveyed to the colon and the rectum and the sphincter to cause defecation. So the defecation centers are under this inhibitory control by the higher CNS, and inhibition can then be released when it's time to defecate at a chosen time. Now, before we even get into assessing the patient with incontinence, we need to look at communication. You must know how to communicate with a person with dementia. I am learning this every day. I only have 2 slides devoted to communication, even though it's really important, but it's a huge, it could be a whole webinar. So please understand that I'm just skimming over this subject. It's very difficult because I really want to talk about it, but like I said, it's going to have to be at a different time. Looking at the communication, and I need to go back one, always approach them from the front. It really freaks them out, gets them scared if you don't approach from the front. And call them by name. That really helps because sometimes they'll remember that. Avoid criticizing, correcting, or arguing. Use a nice tone of voice. You want to keep eye contact with them. Take your time. Go slow with them because the processes are slower. It takes them a long time sometimes to process what you're saying. Respond to the emotions behind the statement and provide brief answers. The emotions behind the statement is so important because they may say something and be angry, but say something totally like the window's open, and it has nothing to do with the window being open. It has to do with something else going on with them that's causing them either pain or whatever. So you got to learn to read them as well. And also the brief answers is important too. Speaking slowly, clearly, limited distractions, and use visual cues when you can, and gestures, you know, play some games. It's like charades when you try to tell them something. Avoid quizzing. That's the worst thing you can do because it frustrates them because they can't get the answer out or they don't know the answer. And joining into their reality. I know that sounds funny, but the most important thing though here, the most important thing is not to argue. You can't pull them into your reality. They're not going to go there. You need to join into their reality. Avoid or focus on their feelings, not the facts. If they, like I said, if they say something, they may be talking about something totally different. In reality, they're having pain or whatever. Validate and redirect if necessary and help them feel safe and happy. That's when you're going to get your best results. So I just want to say that there is a book by Laura Wayman. I've mentioned her before. She has a book called Loving Approach to Dementia Care. It explains this whole concept very, very well, and I encourage you to read it. And any other articles by Laura Wayman. She is the dementia guru. She's the dementia whisperer is what she calls herself. And it really helps you to be able to communicate with these people if you read that. So like I said, this is only 2 slides of it, but you can learn so much online too about communication with them and what their brain is really doing. I do it every day with my father. So it is a difficult thing to learn without getting frustrated. So moving along, we're going to talk about my other favorite subject is incontinence. I really like it to be continence, but risk of incontinence with or without dementia. You know, you can have, I need to go back a little bit here. Oh no, it's on the next one. You can have incontinence without dementia, definitely. Reduced mobility, declining cognitive function. All of these things here are risks for incontinence. Medications is a huge one. Reduced sphincter and muscle tone. You know, a lot of people that are elderly or even not elderly, have kids, whatever, have some pretty weak pelvic muscles, and that can cause a lot of problems with incontinence. So we're going to look really quick at a quick review, and I want you to notice now this is my acronym. I claim the fame here. Some foot. Don't ask me why, but that's just what it spells. So stress incontinence, we know the cough, laugh, squeeze. This is the forceful sneeze or a forceful laugh or cough can cause the leakage. And this is usually due to the pelvic floor muscles being weak. Urge incontinence due to, or urge to urinate, like gotta go right now. Many people who have this type of incontinence are not given ample warning to get to the bathroom on time. So that's a huge problem. Mixed is both both stress and urged. And then the functional. This is a huge thing for people with dementia because it's caused by other conditions, making them unable to get to the bathroom. Like grandma has to get her walker and she has to get up on her walker, which uses muscles and can put pressure on the pelvic floor. Maybe she's not really incontinent, but it just takes her forever to get there. And as dementia develops over time, this type may be more prevalent and possibly more frustrating for to treat, because there's not a real cause. It's different. Overflow incontinence, that results when you're unable to fully empty, such as when somebody has BPH, enlarged prostate, or any type of obstruction, and they can't get it all out. So I call it peeing off the top, because they just go enough to where they've gone a little and then the rest is still sitting in there. It can cause all kinds of problems, including infection. Overactive bladder. Overactive bladder is a condition in which the bladder can spasm, and it can cause sudden, intense, and frequent urges. If they have leakage, then they're called UUI-wet, which is urinary incontinence, urge urinary incontinence that's wet. And then overactive bladder contractions can send you running to the bathroom quite frequently without any leakage, and that's UUI/dry. So there's two different types of overactive bladder. Total incontinence, both bowel and bladder, very, very difficult to manage. And then of course there's just bowel incontinence that isn't up there, but that can cause a great deal of stress between the caregiver and the patient. It's very stressful when they start leaking stool. And they get embarrassed, even though they're cognitively having difficulty. That feeling is still there. The feeling is still there. So you've got to be very, very careful in talking to them about that. And that's, for me, the easiest part. For me, that part, I mean, is the easiest part, to just be very, very nice about it and encourage them that this is not always going to happen, and we need to just let them feel okay about it. Now, acute incontinence, that's going to be things like your infection, your stool impaction, medication, things that you can fix rather quickly. But then there's the transient kind. Now, this, you can see this is a very old acronym, and it's been around forever and ever. And it's the extra P in diapers. Now, I hate the word diapers, but this is how we remember the transient causes. So if you ever forget, you can write the extra P in diapers, and it helps you to remember. The delirium, infection, atrophic vaginitis. These are things that come and go. The restricted mobility, stool impaction. Once you disimpact, they might be just fine. So those are the transient causes, and you want to look for all these before you try to treat somebody. Now, your persistent incontinence, that's going to be things like that pelvic floor is so weak, they've had prostate surgery, there's no muscles in there to even control. The vaginal surgery in women sometimes can cause that. Pelvic prolapse, Parkinson's, strokes, these type of things, they're persistent. They're not going to just go away with disimpaction, you know. Mental or psychological changes. Bladder cancer can be a real big problem for them. Pelvic muscle weakness. Again, the enlarged prostate. Nerve or muscle damage after radiation. I've seen a lot of that in the anal area. That sphincter does not work anymore. It's been fried, basically. Developmental problems with the bladder, or pelvic, prostate, or rectal surgery again, and the bladder spasms. These are kind of persistent here. And you see here the studies done by Devori and Manassian. These show that older age, white race with obesity are particularly strongly related to persistent urinary incontinence, just so you know. So then some of the causes of urinary and fecal incontinence with people with dementia are those functional difficulties, cognitive, psychological, unwillingness, presence of physical barriers, and lack of available care. And lack of available care is really, really one of the most important ones, because they cannot get there, sometimes can't process that. And that whole thing about cognitive or physical impairment, this cognitive impairment makes it difficult for them to process what they're feeling and why they're feeling it. So it's kind of like, yeah, the messages between the brain and the bladder or the bowel don't function quite correctly. And that can lead to incontinence, including these things here: the inability to react to sensation, inability to communicate it, not being able to react to the need, mobility issues, not being able to communicate their need, again, forgetting. Not really, it's difficult. I'll tell you in a minute about forgetting. It's not really forgetting, it's just they can't process that. Not making an attempt to find a toilet. Sometimes they just lose everything to where, no, I don't even know why I feel this way, and I'm not going to go anywhere. And then they just urinate. Getting disoriented and forgetting to where the toilet is, or forgetting to remove their clothes. But there's still ways to manage incontinence caused by Alzheimer's by using the conservative methods, which can be easily incorporated in their routine on a daily basis. The two main predictors, though, there's two main predictors of incontinence in dementia patients. One is their degree of immobility, and the other is the severity of the cognitive impairment. Those are the two main reasons. So looking at how to maintain continence and toileting appropriately, that requires several integrated cognitive and physical skills. As we said, the cortex, pons, blah, 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 all those areas are responsible for what's going on. It's really important that they have something there. These are responsible for the conscious control of social voiding. They don't have that anymore. The cerebral micturition center, the interpretation of the sensory and the detrusor motor control, coordination of the bladder and sphincter. So, you know, between them, between all of these things, the cortex, pons, basal ganglia, cerebellum, and brainstem, they're all responsible for all of those things. So if they're not working right, we have a lot of difficulty. Now, cognitive and physical skill for continence, again, the sensory function, to sense the fullness, initiate voiding or defecation voluntarily in an appropriate place. That's what we need to do. Higher cortical function enables the ability to delay or inhibit it. And then goal-oriented behavior is, again, the motivation to use the toilet and the perception that it's safe. It's going to be safe, hygienic, and private. Very interesting when I was working with children with incontinence, fecal incontinence. And one of the main problems with this one kid, I could not believe him. I just loved him. He was raped in a bathroom by a relative. Yeah. And it turned out that that was the reason for him, and he was very young. That was the reason for his incontinence. Everybody tried to put him in the bathroom, and every time he saw that toilet, he would scream and run, and it was so difficult. We ended up with him, they lived way out in the country. We ended up with him in putting a commode chair outside. Sounds silly, but it worked. And the kid was continent until he grew up enough to where we could actually let him know that that's not something that's going to be happening every time he goes into the bathroom. The sacral micturition reflex that controls the sphincter and the detrusor muscles, that can be affected by neurological defects. Here's the thing. One of the things that I have learned over the years is that, you know, we're not born with the ability to be continent. We're not born with that social skill. When a small child around 3 or 4, let's say, is outside playing, they're busy playing, and they wet. Well, it's not a problem of forgetfulness per se. It's a problem of multitasking in their mind. So playing is what their mind is on, and that's what they want to do. And sometimes they're unable to process 2 things at one time. So then they have an accident. Well, the same goes for somebody who has dementia. With a person with dementia, their mind is unable to process 2 different things at once as well. So they've lost that ability, just like the child had to learn it, they will lose it. And then sufficient mobility, manual dexterity, they have to be able to adjust their clothing and clean themselves, and there are some things that can help with that. Where mobility and dexterity is impaired, the ability to communicate toileting needs, and the fact that they need assistance is required. They have to know that they need assistance, and you have to be able to read that. Now, impaired mobility is considered by some to have a stronger correlation with incontinence than the cognitive decline, and I totally agree with that. You know, the whole thing is, in dementia, it's related to the multifactorial breakdown in compensatory mechanisms that affects the older people. So it's very important that you look at, can they physically get there or not? Is it really cognitive or is it physical? Now, as the cause of incontinence in dementia is usually multifactorial, a holistic evaluation is essential. And the basic evaluation is no different format than that you would do for anybody with incontinence, because you need to rule out these things, exclude the constipation, vaginal atrophy, abdominal mass, or prostate enlargement, organ prolapse. Those things need to be excluded before you even look at how to help this person. So it's no different than anybody else. You're going to do for both male and female, you're going to do a post-void residual. That's important, and a urinalysis. A bladder and bowel diary is recommended 3 days for urinary symptoms and 1 to 2 weeks for bowel symptoms. Okay, so that's the general rule here. And you're looking for constipation or incontinence. It depends on what you're looking for. Mobility and dexterity, including the need for and availability of the caregiver's assistance. And then, of course, for men, they've got to have a PSA. That's very important. Psychological consequences. Oh my gosh, the consequences, including the effects of each of these. Their daily life, their quality of life, their attitude, all of these things play a part in this. Their mobility, assistance required, and who's giving that assistance. Let me tell you, daughters giving assistance to fathers is very difficult. I'm the daughter, not the nurse. You know, who is taking care of this person? If it's a child of them, it's very hard. Suitable clothing. You've got to have clothing that works. Severity of their cognitive impairment and behavioral disturbances. You know, the behavioral disturbances that may affect continence and the person's cooperation with toileting is huge. Now, we got to look at this. Are they really incontinent, or are they having toileting difficulty? And incontinence, of course, signifies a failure in the mechanisms associated with normal storage or involuntary passage of urine or stool. Toileting difficulty is totally different. It's failure to toilet appropriately, and it can result when the function is unimpaired and the awareness of the need to pass urine or stool exists. So Stokes did this study on this, and it's in your references as well, but it's very interesting. There is a huge difference, and you have to determine which is what. Now, behavioral characteristics of toileting difficulties. If you have somebody who is smearing, for instance, not so good. It does happen. Wrapping and parceling. They're not sure what this is that they're supposed to do with it. Passive or active wetting and using inappropriate receptacles. I can remember one of my sons, I hate to say this, used to wake up in the middle of the night, walk out and urinate right in the heater vent. You know, I mean, that's a kid, but different lecture, but it was really funny. That was a very inappropriate receptacle. And these can result from toileting difficulties, all of these. You have to watch that. Challenging behavior can be due to the person trying to express a need. You need to look at the feelings, not the behavior. So using an inappropriate receptacle, that can be that they can't recognize the correct place to go. You know, agnosia. it's called, the inability to interpret sensations and hence to recognize things, typically as a result of brain damage. So the approach in managing incontinent people with dementia and people without are basically the same. So reversible causes should be explored and treated first, like I said. And then there could be a type of management that you could do with a patient in a dignified and supportive way. You need to look for that. And the condition may affect their options, but the level of cognitive impairment or behavioral disturbances, that can definitely have play in the options available for management. So when you look at management, you have to look at everything. Bladder retraining, for instance, and pelvic floor muscle exercises have very little value for people with severe cognitive impairment. That's one of the first rules of pelvic floor muscle exercises. Can they do them? Cognitively understand. And behavioral disturbances, but they may be able to work in the early stages. So early stages, get those pelvic floor muscles strengthened and ready so that when they're not cognitively able, you can actually have some pelvic floor muscle tension going on. The person may exhibit signs of wanting to go. You need to look for these fidgeting, look for things like pulling at their clothes. The better the caregiver knows the patient or the person, the more apt they are to recognize these signals. So it may not even be as simple as what she's doing in the middle here, holding themselves or holding their abdomen. It may be something like tapping on a table or anything, but you've got to read that, figure out what it is, and individualize their management program based on what their self-care abilities are and their level of impairment. Now, dysfunctional behavior can be addressed using individual care planning, setting goals, realistic goals. And these goals should be set considering these 4 things. What can they do? What will they do? And who will they do it with? And how will they do it? I can tell you, a lot of people will stick with one caregiver in a family. And there's no way on this earth that some people would allow anybody else to go in the bathroom with them. So you really have to look at that. If a person has the capacity to retain the benefits of an experience, especially within the early stages of the disease, then relearning is possible. But relearning involves starting at the end of a sequence of behaviors and concentrating on what the person is able to do. A lot of people with dementia, you can't teach them a thing, but they can feel the feeling of doing it right and the feeling that you give them, the feedback. Behavioral technique to help manage incontinence. There's, individualized toileting programs may benefit. Toileting assistance can be in the form of time voiding or habit training. There's a limited evidence to suggest, though, that any of these techniques are successful on their own. Habit training along with time voiding can, combined interventions there. They may reduce the number of incontinent episodes, maybe. Timed voidings, predetermined toilet visits can be effective when used with additional interventions. Like I said, absorbent products are good, staff education is wonderful, and possibly medications. So dementia makes urge incontinence worse because the signal of that urination is needing to happen may be misunderstood, like I said, or misinterpreted. Sometimes they give them some anticholinergics, but it depends on the patient and what their meds are, etc. Habit training, that uses bladder diaries. You use a diary to determine the voiding pattern and when toileting a person is predetermined. I call this training the caregiver. Prompted voidings teaches the patient to urinate on their own, hopefully by prompting them to do it every 1 to 2 hours, see if they're wet and soiled, and give them some positive reinforcement. This method requires motivated caregivers, very motivated caregivers, and a safe environment near the toilet. You need to consider things such as the adaptive clothing. I'm going to go through some tips here really quick because I'm almost out of time, but you need to maintain their bladder health. Avoid carbonation or caffeine, limit the liquids before bed, avoid spicy or acidic foods, and eat plenty of fiber to avoid constipation. Have them exercise regularly and offer water every 6 to 8 hours. I'm sorry, spacing out 6 to 8 glasses a day. Those are just some tips that you probably all know. Adaptive clothing, huge. Oh my gosh, it can make all the difference in the world as far as their being functional. Replacing buttons and snaps with Velcro and zippers. It gives more control to the patient, encourages the independence, and gives the patient much more privacy if they're able to go into the bathroom by themselves and undo their pants. Some people with dementia will not give up their Levi's or their jeans and struggle with that, but refuse to give it up. So you just have to work around that kind of stuff. So there's also incontinence products for all ages. And you know, one thing that's really interesting is if you have somebody who is taking off their pad all the time, taking it off, you need to think about the fact that they don't like that pad. They don't like it, so they take it off. So find something different, maybe a washable incontinence underwear, or even one of these briefs, the disposable briefs. Then there's the things that, you know, most people, it's really hard. You have to watch them carefully, because in the beginning stages, especially, because they will take this pad and let it dry and use it over and over and over. If you're not watching, you have to, they have difficulty sometimes understanding their use and their disposal. You really have to watch them with that, because it happens. Handrails. You know, when you think about limited or restricted mobility, we need to improve that with all of our elderly. But the bathroom environment needs to be uncluttered, clean, clear visual signs, written signs, pictures, whatever you need to identify the toilet. One of the things is a black toilet seat with white on the inside is very, very helpful to just trigger them that that's the toilet. Sometimes, you know, people will sit on, if there's a little stool in the bathroom, some people have a little stool there in case the person loses their step or needs to sit down. Yeah, they will sit and urinate on that stool if they don't have clear directions. So, and mirrors can really confuse people with dementia. They think somebody's in the bathroom. So you have to think about that if you see that happening. Now, outside or in public, plan ahead. Time your stops around the bathroom. Be prepared for accidents and take those pads and extra clothing, because you're going to probably need them. So, you know, everybody reacts differently to incontinence. Some may find it upsetting, while others recognize it as just part of their condition. The best way to approach the situation is with understanding and genuine interest for improvement. You must speak or address the issue in a calm manner. You can't come in and say, oh my gosh, what did you do? Da, 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 da. That will get you nowhere. Scolding or looking upset or frustrated just makes it all the worse. So maintaining continence for people with dementia is complex due to the multifactorial nature of the disease, along with the additional complication that many older people have, other chronic medical conditions. So it's important to have a comprehensive assessment in order to understand the effects of cognitive and functional dysfunction. Regular review is also very important, because their function may decline as the disease progresses. So you have to look at what is best to build a relationship with the patient. What can you do to have the caregivers to identify the changes in their cognitive function so you can keep up with what they need. As it progresses, your care needs to progress as well. The goals of management should be aimed for maintaining their self-care and independence for as long as possible. And that's really important for these people. It helps them psychologically, and it also helps the caregivers. There are some references here for you to look at, and they are all in the notes. And then I just want to say thank you for listening. And I have to point out the heart on the mountain. This is El Capitan in Yosemite National Park, where I'm from, and this is the heart. I don't remember when that chunk fell out, but it makes the heart in the mountain, and that's what I love about it. So with that, I will turn it over to Brooke, and Brooke can take it from there. Thank you for listening.
Great, thank you so much, Kelly. That was a really wonderful and very rich and detailed presentation. Just as a quick reminder for those who registered as healthcare professionals, CE credit certificates will be emailed to attendees within 10 to 14 business days. If you do not receive your CE certificate, please check your spam folder first and then contact us at marketing@shieldhealthcare.com so we can assist you. Next slide, please. If you enjoyed today's webinar, you can find more educational information on Shield Healthcare's online community site. This is where we will also post the recording of today's webinar. Our community site has over 2,200 educational articles, videos, free booklets and guides for download, and lifestyle resources provided by lifestyle specialists Erin Baker and Laura Cox, also from parents of children with special needs, and much more. You can find us at shieldhealthcare.com/community. And here are some of the guides you can download also from shieldhealthcare.com/community. Free guides, including living well with incontinence and aging safely at home, both relevant to today's presentation. All right. Oh, and so we don't have a slide for this because I didn't think to put it in, but I also wanted to remind everyone that we have begun Shield Healthcare's 19th annual Caregiver Contest. That's open to healthcare professionals and to family caregivers alike. This year, our question for caregivers, both professional and family, is how has COVID changed caregiving? Entries are 150 words or more. We have 3 grand prize winners and 5 runners-up. So if you're interested, please go to shieldhealthcare.com/caring to learn more. Okay, at this time, we're going to open it up for questions. We do have a lot rolling in, so we'll try to roll through as many as we can, as quickly as we can. Kelly, first question. My husband is a patient with Alzheimer's and suffers from pain in the area behind the back, even though he is taking nerve treatments. He continues to complain about pain and difficulty moving and walking. I'm confused whether he suffers or is this the effect of Alzheimer's?
You know, it's difficult to say because, like I said, they can complain of one thing and have it be definitely something else. So it's hard for Alzheimer's patients to determine exactly what that pain is from or where it is. If he's feeling pain in the back, I don't know if he's had a history of back pain or back surgery or anything like that. You'd need to look at what his history is. And if he's had anything like that, then yeah, it probably is back pain. But again, he could say it's back pain when it's really bladder pain, or it's back pain could be kidneys, or, you know, it could be just about anything. So the combination, and I don't know, of course, what his cognitive ability is either. So the combination of, yes, he's got Alzheimer's, and yes, he's got back pain, you know, and again, pain with moving, that tells you right there that it's something that hurts when you move. Or is it because he doesn't want to move? You have to really be able to, I guess it's a guessing game, really it is, unless you know that he has some back injury or some nerve, he's getting treated for nerve pain, I think you said. Is that what the question had in it, Brooke?
Yes, he's getting treatment for nerve pain, correct.
Okay, so it depends on what that treatment is. It's really hard to tell. It's a game player. You have to figure it out and watch him every day. If he's having, like I said, if it's pain in his back, it could even be kidneys. You just don't know. Well, I don't know what his history is. You'd have to know his history.
Great, thank you so much. Next
That's
question.
not much help, but
Thank you. Next question. What is smearing, wrapping, and parceling?
well, it's not nice. Smearing is if they take stool, much like a little baby in their crib. I'll never forget my son doing that. I thought he was sleeping, and I went in there and he had painted the walls, completely painted them. I mean, I thought he was sleeping for an hour. And yeah, it was a mess. So they'll take stool and smear it places, or they may not have cleaned themselves and have smear in their underwear or their pad or something. But parceling and packaging, they'll definitely be taking stool and wind it up in the toilet paper. And I mean, it's many different things, but mostly it's just this it's unknown what they need to do with it. You know what I mean? If they take their pad down or their underwear down and there's stool in it, they don't know what to do. And they might want to hide it. So they'll wrap it in toilet paper. That's packaging or parceling. So it has to do with, you know, not knowing what to do with it.
Okay, great, thank you. For the inpatient setting, is it detrimental to check a patient with dementia every 2 hours for incontinence at night?
Oh, you know what? I'm all for that because they need to be turned every 2 hours if they're not turning themselves. I would definitely do that to keep their, you know, if they get upset though, there's a difference there. If they're scared and they get upset, I would wait a little bit longer. If their skin is intact and you're not worried about their skin damage at that point, you have to weigh the odds. Is it worse to wake them up and have them screaming if they're sundowners or whatever? Or is it worse to let their skin sit in urine? So you have to know the history. You have to know what their skin is like. If they have absolutely no problem with their skin and they're turning back and forth, I would let them sleep. But again, if they're having problems with their skin, or if they're unable to turn and reposition themselves, I would turn and reposition them every 2 hours, check for moisture and change it.
Great, thank you. How long did you say to do a urinary diary again?
The urinary diary is I believe it was 2 to 3 days. And the other one is longer because of the, you know, the stool. You really want to check that really often. I mean, let them go a longer time because you can't tell exactly what's going on with them. You want to make sure that your diary is completely, you know, done completely, because a lot of times people forget to write down when they had leakage. You know, the urinary symptoms, yeah, you're going to go 1 to 2 weeks for bowel, but you're going to do a bladder diary every 3 days, for about 3 days for the urinary symptoms. And in that 3 days, what you're going to see, if you can do it right, is to see how often they urinate, how much they urinate, how much they drink. You got to add that in there. What they're eating, I would put that in there too. Are they having coffee? If they're having coffee in the morning, definitely put that down, because you're going to be wanting to look at all of the different things that has to do with their voiding pattern. And once you know that, you want to stick to the same pattern of intake so that you can then stick to the same pattern of urinating. So once you know that they're going to go, because of what they're eating and drinking, etc., they're going to go every couple of hours. Let's say that 2 hours, every 2 hours, this person is needing to urinate, whether it's in a pad or in the toilet. But let's say about every 2 hours. That's going to trigger you to go, okay, every 2 hours, great. I'm going to take them to the bathroom every 2 hours. If you see it real sporadic, then it's not going to work very well for you. You just can't. But the main thing is you've got to have caregivers that are on top of it, because if they don't keep track correctly, and if they don't do it every 2 hours or whatever the patient is, some people don't go every 2 hours. Maybe it's every 3 hours. but you want to try to get to that schedule. You want to see what the schedule is so that you can follow that schedule and promote their independence with it. And that goes along with everything else from you know, fixing their clothes so they can open and close it. And of course, then you also have to look at their mobility and their dexterity. That has to be looked at as well, because especially though that caregiver, got to have a good caregiver that can do that.
Great, thank you. And I think this question relates. We're going to try to squeeze in just a couple more questions. I realize it's the top of the hour, but when should you resort to diapers?
When it becomes a problem with either soiling your furniture. You can put things over your couches and stuff, but I don't call them diapers, I call them briefs. Here's a good example. If a patient is leaking at night, let's say they've got a bowel problem and maybe have had bowel surgery, so they've got a really high motility and you know, less bowel to go through, so they're going to have some quick bowel movements. I would say that if that patient is getting up and leaking on the way to the toilet, having trouble getting there on time, having trouble with leaking in the bed, when it becomes a problem, let me tell you, briefs are not a bad option. I have seen people use briefs just for nighttime, because that patient cannot cognitively or physically get to the bathroom on time, or because they've got short bowel syndrome. Short bowel syndrome can throw them in a tizzy. And I'm talking leaking all the way to the bathroom. So put a brief on them at nighttime. And then, you know, take that off in the morning when you can be more aware when they're, you know, needing to go to the bathroom. It all depends on what's going on with the patient. I have no problem with putting people in incontinence products, no problem whatsoever, if they have the need, and they, especially with dementia, it gives them some security as well. You know, that feeling of security, like, okay, well, if I leak, it's not going to go on the floor, kind of thing. So yeah, whenever the need presents itself.
Great, thank you so much. These two questions are related, so I'm going to read them both. Do you have any tips or resources for working with individuals with IDD, Alzheimer's, and incontinence? And then also, what is the last name of author Laura that you mentioned earlier?
It's Laura Wayman. It's W-A-Y-M-A-N. She is just absolutely wonderful, and I just can't say enough about her. I absolutely love her. I actually do go to her support group online and listen to everybody there and what they're doing. And I got to tell you, there's nothing better than a support group. And you know, I take care of my father, so I'm dealing with this daily, with this dementia as well as incontinence. And you know, the psychological effect on the caregiver, especially being a daughter, is huge. And Laura has just made my life a whole lot easier, and the other people in the support group. But it is so important, if you're a caregiver, to get in a support group. Even if you teach the stuff, let me tell you, it's totally different when it's your own family member. So nurse or no nurse, continence nurse or no continence nurse, it's very different. Now, irritable bowel. That is so hard. And because I deal with short bowel with my family member, I know how hard it is to deal with. I'm not sure, again, what that question about irritable bowel was, is how to manage that.
That may have been an earlier question. This particular one, we were interested in resources or tips you might have for working with individuals with IDD, Alzheimer's, and incontinence. Beg your pardon.
Okay. You know, I would go right to dementia management, because they're going to deal with all the issues. And, you know, There's support groups, there's books, there's all kinds of information on it. And I would reach out to Laura Wayman, I think it's W-A-Y, and she's online. I mean, go to her, she will get you in. The other thing is, now Alzheimer's Association, I have gotten so much information through them. And the Alzheimer's Association is absolutely wonderful for literature, for instruction type literature, for anything having to do with anybody with dementia. It's wonderful. And they will reach out to you as well. Once they know you have somebody with dementia or Alzheimer's, they keep up with you and until you tell them to stop. But they will call you, they will email you and say, how's things going? You know, is there anything I can help you with? What can I give you for this? What kind of literature do you need? Where do you need to go? What questions do you have? They are wonderful. That's where I would go. That's where I would go, and that's where I went, but that's where I would go, definitely.
Great, thank you so much. We are at 6 past the hour, so we'll stop questions here, but there are several more questions that came in about your parents or your residents, and rest assured we will get back to you and we'll answer your questions one-on-one with the email that you used to register for the webinar. So at this time, we're going to wrap things up. Thank you so much, Kelly, for an amazing presentation. You were always a wealth of knowledge. We appreciate your insights. And we look forward to seeing everyone at our next webinar. For now, have a wonderful rest of your day.
Awesome. Thank you so much, Brooke. Bye, everybody.